Hey, welcome to Not So Complicated, and it's another beautiful day to solve clinical cases, which will lead to one step closer to our USMLE dream, right? So it's day 13, clinical case discussion 13. So here is the case without further delay. A 52-year-old female presents to the emergency department with 8 hours of right upper quadrant pain, nausea, and vomiting. She reports similar milder episodes after fatty meals over the past month. Her medical history includes obesity with BMI, which is body mass index of 32 kg per meter square, and type 2 diabetes, which is controlled on metformin. So vitals include temperature 38.0 degrees Celsius, blood pressure is quite normal, pulse is slightly raised, and respiratory rate is normal 18 per minute. Examination reveals right upper quadrant tenderness and a positive Murphy's sign. So it is a case of cholecystitis, that even acute, and there is no signs of jaundice, right? The labs show WBC 13,000 per microliter, and then total bilirubin is slightly raised 1.8 mg per deciliter. Alkaline phosphatase is also slightly raised, and AST 60 units per liter, ALT 55 units per liter, amylase 80 units per liter, which is in normal range. And ultrasound shows gallstones, gallbladder wall thickening 5 mm, and pericocystic fluid, right? So it is a case of cholelithiasis that exacerbated the acute cholecystitis. So what's the question? The question is that what is the most appropriate next step in management? Okay. So option A is administer IV morphine for pain control. Yes, we have to control the pain. And option B is IV antibiotics and plan for cholecystectomy. Okay. And C is order an endoscopic retrograde cholangiopancreatography, ERCP. And D is start orthodeoxycholic acid for gallstone dissolution. And then E is to perform percutaneous cholecystectomy. So let's debunk each of these options and choose which is the most better option to do at first. So it should be the immediate step of management. So right, so let's go. The option A is administer IV morphine for pain control. Okay, pain control is important in acute cholecystitis because it is severe, but IV morphine is not the first step. Why? Because we have to control pain, we have to control infection before pain, right? So infection control is more seriously needed than pain. So this is not the first step. Aggressive antibiotics and surgical planning take priority to address infection and prevent complications like perforation, right? So morphine may also cause sphincter of RI spasm. So this is the infection of ampulla, this is the sphincter of ampulla of Vater, right? So also it potentially worsens bile stasis due to sphincter of spasm, and IV ketorolac or hydromorphone is preferred after initiating antibiotics and fluids. The patient's pain is secondary to inflammation, which antibiotics and surgery target directly. So this option might not be the answer. And in Charcot's triad, as I have mentioned in the figure here, is that fever, which is also rigors, and jaundice, and then right upper quadrant pain. So there is difference between cholangitis, cholecystectomy, and cholecystitis. So cholecystitis is the inflammation of gallbladder wall due to irritation of gallstones, right? The gallstones can it can occur like acalculous causes or calculus causes. I'm so sorry, I'm stuttering. And then ascending cholangitis is the inflammation which shows typically Charcot's triad, and cholecystectomy is that the gallstones are now in the common bile duct, that is what like hepatic biliary tree, intrahepatic biliary tree or extrahepatic biliary tree. So this is our option A. The option B we have is initiate IV antibiotics and plan for cholecystectomy. This might be the answer because this patient has acute cholecystitis diagnosed by RUQ pain, positive Murphy's sign. Murphy's sign is actually like you will insert your finger inside the subcostal region of the patient and ask him or her to breathe. And if there is pain, the patient will catch the breath, and you can see it in the expression of the patient, facial expression, and that is positive Murphy's sign. We'll talk about it, its pathophysiology or the mechanism why the pain is induced later. And fever, leukocytosis, USG findings meeting Tokyo guidelines, TC8 in diagnostic criteria. This is a very important guidelines. We have to remember this at all cost. Here is attached. So The most appropriate next step is to initiate IV antibiotics to treat infection and plan for cholecystectomy within 72 hours for uncomplicated cases, like ACG 2018 guidelines, right? So early cholecystectomy, that is laparoscopic, is preferred, which is definitive treatment. So this is the very highly likely option. So the Tokyo Consensus Guidelines diagnostic criteria for acute cholecystitis is that there are 3 findings. The local signs of inflammation should be there, that is Murphy's sign, right upper quadrant pain, tenderness or mass. And B is systemic signs of inflammation like fever, elevated CRP, which is C-reactive protein, which is acute phase reactant, and third point is elevated WBC count. And in imaging findings, it should be characteristic of acute cholecystitis. So in a suspected diagnosis, there is 1 item in A plus 1 item in B, like the above criteria. And in definitive diagnosis, 1 item in A plus 1 item in B plus C should be there. So that is how we that is how we fix it, that if the case is of acute cholecystitis or not. So that is Tokyo Consensus Guidelines for you. The third option we have in here is other an ERCP, that is endoscopic retrograde cholangiopancreatography. So ERCP is indicated for cholecystectomy exactly, which is common bile duct stones. As you can see in the USG findings in here, there is dilatation of common bile duct because there is a stone in there in the distal part of common bile duct, right? So there is the blockage of flow of bile that is causing dilatation of common bile duct, which will cause jaundice, cholangitis or pancreatitis with findings like elevated bilirubin greater than 4 mg per deciliter. But in this case, the bilirubin is just 1.8 mg per deciliter, so there is not a case. It is not a case of cholecystectomy. So we might not need an ERCP. And also abnormal liver enzymes, ALT, AST, should be greater than 2 times normal. This patient has mild bilirubin, ALP elevations likely from cystic duct inflammation, not CVD obstruction, exactly. And then ultrasound shows no CVD dilation, but this is the case where there should be CVD dilation. But in our case, there was no CVD dilation and only gallstones, gallbladder thickening of 5 mm and pericholcystic fluid were there. And also amylase 80 units per liter rules out pancreatitis, obviously. In the pancreatitis, the amylase and lipase enzymes are increased rapidly and in maximum amount. ERCP is invasive, that is 5 to 10% risk of pancreatitis or bleeding can occur in ERCP, unnecessary here, and delays definitive cholecystectomy, so we should not do this. The fourth option we have here is start ursodeoxycholic acid for gallstone dissolution. Ursodeoxycholic acid, that is UDCA, is usually used for non-surgical gallstone dissolution in asymptomatic cholelithiasis or mild biliary colic requiring small, less than 10 mm, and also cholesterol-based stones and a patent cystic duct, that is 6 to 12 months if for effect, 50% is recurrence occur. Okay, this patient has acute cholecystitis requiring urgent antibiotics and cholecystectomy, not medical dissolution. And also UDCA is ineffective in acute inflammation and delays definitive treatment. The USG finding that I have attached in here is a posterior acoustic shadow. There is a gallstone in gallbladder, and that gallstone in USG actually reveals a posterior acoustic shadow that you can see in here, and that is just the information I wanted to provide, right? So this option is also unlikely. The final option we have is perform percutaneous cholecystectomy. Cholecystectomy, it's not cholecystectomy, it's cholecystostomy, right? So percutaneous cholecystostomy, that is tube drainage, is reserved for high-risk patients like elderly and with severe comorbidities. Not only comorbidities, it is reserved for patients with severe comorbidities unfit for surgery. That is almost temporary gallbladder decompression is done by percutaneous cholecystostomy. And this 52-year-old patient has no contraindications to cholecystectomy. That is, she has stable vitals. There are no severe comorbidities, even if there are diabetes, type 2 diabetes and obesity. They are not severe in this case. And ultrasound shows uncomplicated cholecystitis, right? So cholecystectomy is definitive, while cholecystectomy is a bridge therapy. 10 to 20% complication rate, example tube dislodgement are there. So this is also unlikely case. And the figure that I have attached in here is of laparoscopic cholecystectomy, there are pots to be inserted in different regions for cholecystectomy to happen, right? So the main working pot is of 10 and in the sewn location, and in umbilical region there is camera pot 10 in diameter obviously, and then left hand working pot that has 5 and assistant pot 5 of working pot, right? So basically camera angle is of 30 degree, so that gives the maximum vision. Okay, that is what you have to remember. And the best management is initiate IV antibiotics first, and then plan for cholecystectomy. So the mechanism of development of cholecystitis is that there is the development of gallstones first, that is in 90% is cholesterols, right? So that stone blocks cystic duct or common bile duct, and that will increase the pressure, that is pressure buildup occurs causing dilatation and swelling, right? And then that will irritate the gallbladder wall, those stones will irritate the gallbladder wall and cause inflammation, and that inflammation occurs around occlusion, and that will lead to bacteria invasion. So that is what it occurs, that the pain in cholecystitis is colicky pain if resolved after duct dilates and stone falls back into the gallbladder, and that pain radiates to the back, that is in Murphy's sign also, and it leads to pain increase in GGT, that is gamma glutamine levels also. So in cholelithiasis, which are gallstones, the most common case is of that, right? So it is made up of cholesterol stones in most common cases, and the four apps are the risk factors, that is female, fat, fertile, and 40, that is 40 is age, and bilirubin, that is extravascular hemolysis and biliary tract infection. So why cholelithiasis? The cholelithiasis actually, these gallstones, there is an anatomical variation in gallbladder, that is there is a Hartmann pause, right? So in that Hartmann pause, it is very vulnerable that the gallstone will get obstructed in that region. So in if the gallstone is obstructed in that region, then bile cannot be drained out of gallbladder, so it will lead to gallbladder dilatation too. And also cystic duct will lead to symptomatic cholelithiasis to acute cholecystitis, perforation, and peritonitis is the risk factor or the complicating factors, and in acalculus severely ill, right? So if the cholecystitis goes to the chronic case, then gallstone ileus occurs, that will lead to porcelain gallbladder. So this is a very high yield term in here, porcelain gallbladder, you have to remember this, and gallbladder carcinoma in long term, right? So the clinical features of acute cholecystitis is fever, anorexia, nausea, vomiting, tender breathing, fat intolerance, and acute severe right upper quadrant pain, obviously, which may radiate to back, increasing with breathing. And there is feeling of fullness too. The Murphy's test, I have talked about it here. So what actually happens, why there is pain in Murphy's test, right? So diaphragm pushes the liver and gallbladder downwards on inspiration, that is what happens, right? So the distended gallbladder is momentarily compressed on deep palpation as we insert our fingers in subcostal region, right, during the late inspiration phase of breathing. So that is why it occurs, like diaphragm will push the liver and gallbladder to the lower region, and we are pushing our fingers to the upper region. So as we touch the gallbladder, there is pain elicited during inspiration, right? So diaphragm will come down during inspiration, obviously due to the volume expansion of lungs. So that is why Murphy's test occurs, right? So what is the management? Obviously the management immediate is IV antibiotics, as we have talked earlier. We usually give ceftriaxone, which is third generation cephalosporin, 1 gram IV q 24 hour plus metronidazole 500 mg IV q 8 hour for 5 to 7 days, adjusted per culture if available, and covers gram-negative and anaerobic pathogens. And IV fluids are also given, which is lactated ringers 1 to 2, which is also ringers lactate, obviously, 1 to 2 liter bolus, then 100 to 150 ml per hour to maintain perfusion of BP 130 by 80 mmHg, and urine output greater than 0.5 ml per kg per hour. And for pain control, we give IV ketorolac 30 mgq 6 hour, or hydromorphone 0.5 to 1 mgq per hour after antibiotics, avoiding IM morphine due to slower onset and sphincter of aortic spasm risk, right? So nil per oral, that is NPO, nil per OS to rest the gallbladder, reducing bile secretion, obviously. So we do not feed the patient from oral region. And then the surgical management is cholecystectomy, which is definitive management. Laparoscopic cholecystectomy within 24 to 48 hours, 95% is success rate, and less than 5% is of conversion rate. So conversion rate occurs like why conversion occurs. So the conversion in here means that if you are doing laparoscopic cholecystectomy at first, but there arise the complications, that complications lead to the open cholecystectomy. That is what conversion rate is. So less than 5% is conversion rate is in laparoscopic cholecystectomy, and it delays increased perforation risk. Intraoperative cholangiogram is also done if common bile duct obstruction suspected, but it is not suspected in here, to rule out cholecystectomy, obviously. And the complications is bile duct injury in 0.5%, infection in 2 to 3%, and bleeding. So there is a procedure attached for laparoscopic cholecystectomy, as I have talked earlier. 4 small incisions are made in the abdomen for insertion of long surgical instruments and the surgical video camera, as I have talked earlier. And also the surgeon views the gallbladder and surrounding structures on a monitor connected to the camera, right? So the surgeon manipulates the long instruments, which are these ports outside of the body, while viewing the procedure on the monitor. That is how we do that. And also there is a triangle, Calot's triangle there. The Calot's triangle there, there is artery, cystic artery, that must be ligated before doing any cholecystectomy to decrease the risk of hemorrhage. And the supportive care we have to do is monitoring, check WBC or bilirubin and vital Q 12 hour, persistent fever or WBC elevation such as abscess or perforation, repeat imaging. And also glycemic control should be there. Adjust metformin, add insulin if needed, glucose 150 to 180 mg per deciliter to optimize healing, right? So in long-term reason, we have to modify the diet, low-fat diet post-recovery to prevent reoccurrence if surgery delayed. And in follow-up, we have to do the clinical visits 1 to 2 weeks post-op, monitor for post-cholecystectomy syndrome, that is 5 to 10% cases, and prognosis is 90 to 95% resolution with early surgery and mortality of less than 1% in uncomplicated cases. So that is how we finish our case. Subscribe for the next cases, and thank you for staying with me. We will crack our USMLE by gaining 260 plus scores for sure. Thank you.